Are we live? I think so. So go ahead and click click your PowerPoint. All right. Can you guys see the slides? All right. Okay. So welcome to the obstetric theme of GASOC's Journal Club. We've got two papers to present today. The first is on anesthesia-related maternal mortality in low and middle-income countries, and the other one is on the outcomes of coaching-based WHO safe childbirth checklist. So we'll get started. So just a bit of background. Yeah. So I'm Soha. I'm an obstetric registrar, working at Royal London Hospital and doing academic work at Queen Mary's University. Do you guys want to introduce yourselves?
Yeah, kind of. I'm Faith Robertson. I'm a Harvard med student, but I'm here getting a master's in global surgery for the year.
Brilliant. Let's get started then. So just a bit of background. A quarter of a million women die every year during or after pregnancy and childbirth, and 99% of these are in low and middle-income countries. Obstetric surgery is life-saving and part of comprehensive emergency obstetric care. So often with most complications, if a woman's bleeding, she has severe preeclampsia.
Did you have a question? Yeah, the echo is pretty bad. Whose side is that on? Yeah, if you guys could mute. You want to try again?
On the YouTube channel. Yeah. So as I was saying, obstetric surgery is required for most obstetric emergencies, including obstruction, hemorrhage, preeclampsia, the biggest killers really. Cesarean section is the most widely performed operation in Africa, and it goes without saying that you can't have safe surgery without safe anesthesia. But to make matters worse, pregnant women are a particularly high risk group from a surgical and an anesthetic point of view because of all of the physiological changes that happen in pregnancy. So the need for safe, affordable surgery and anesthesia in LMICs has long been recognized, and especially since the Lancet Commission. However, in LMICs, there's a paucity of physician, anaesthetists, lack of infrastructure, drugs, equipment, And the risk factors contributing to maternal mortality from anesthesia in LMICs is not, and the burden of the problem is not really well known or understood. And the factors that contribute need to be identified and further quantified. So this systematic review aimed to answer a couple of questions. It aimed to quantify the risk of anesthesia in pregnant women who have an obstetric procedure in LMICs. What proportion of maternal mortality is attributable to anesthesia-related complication, and how this varies between geographical locations, between different types of anesthesia and different practitioners. So the population was pregnant women in LMICs categorized by the World Bank regions. The intervention was anesthesia for an obstetric operative procedure. There were several comparisons made, whether this happened in a rural or an urban setting, whether it was physician or a non-physician administering the anesthesia, and whether it was a general or a regional anesthesia that was given. And the outcomes were anesthesia attributable maternal deaths, maternal and fetal complications. So it was a systematic review that was pre-registered and followed PRISMA guidelines. It was a comprehensive search using Medline, Embase, Scopus, Web of Science, and the WHO library and Global Index Medicus. Studies were selected in 2 stages by 2 independent reviewers and included all papers that had pregnant women with anesthesia outcomes in LMICs. Excluded all high-income countries, non-pregnant women, case reports, and studies published before 1990, as well as duplications. Quality assessment was carried out by 2 people as well, using the Newcastle Ottawa scale and prevalence scales. So as I said, the primary outcomes were maternal mortality directly or indirectly attributable to anesthesia. And secondary outcomes were maternal fetal outcomes, complications associated with anesthesia, and risk factors contributing to these. Subgroups were chosen a priori and included the geographical location, the year of study, income groups in urban, rural settings, regional or general anesthesia, and physician or non-physician practitioners. So we started off with nearly 12,000 citations, and this was numbered down to 140 studies in total. 25 studies gave information on risk factors related to anesthesia complications. 44 studies and nearly just over 500,000 pregnancies gave information on anesthesia attributed deaths in pregnant women undergoing surgery. And 95 studies with 32 million pregnancies gave the rate of anesthesia attributable maternal mortality. So looking at the quality assessment and risk of bias, the first chart is prevalence. The prevalence data quality assessment using a prevalence tool. And you can see that the overall risk of bias was deemed to be low in 65% of studies. And in terms of quality, Newcastle Ottawa scale and the lower one, where comparative data was available, for selection, there was a low and medium risk of bias. There was a higher risk of bias for comparability and a low risk of bias for ascertainment of outcomes. So looking at results, and this table shows the mortality rates from anesthesia in women undergoing obstetric surgical procedures. You can see that the overall rate of death from anesthesia is 1.2 per 1,000 women undergoing surgery, with the worst rates in sub-Saharan Africa of 1.5%. So if you calculate this based on the number of deaths a year, that's about 8,000. No, that's not. I'll come back to that in a minute. So the worst rates are in sub-Saharan Africa, with the worst rates in the rural settings and in low-income countries. there wasn't much of a difference in terms of year, which means it hasn't really improved substantially with time. Studies published before the year 2000 and after the year 2000 were pretty similar. This table shows anesthesia attributed maternal mortality in LMIC. So of all those who have died from whatever cause, how many died from all those mothers who've died, how many were due to anesthesia? And that was 2.8% of all maternal deaths. So if you calculate that based on all maternal deaths, that gives you about over 8,000 women a year who die from anesthesia. The patterns are slightly different here, I guess, with Middle East having go back one, sorry. The rates in the Middle East and North Africa having a higher death, and that might be because of more availability of surgery, as well as Latin America and Europe. And this is a map just showing the proportion of anesthesia-related maternal deaths globally. So you can see Brazil's pretty bad. Okay. Looking at risk factors specifically, when you compare general anesthesia versus spinal or epidural, predominantly spinal because epidurals aren't widely available, you can see maternal death is almost 3 times as much in general anesthesia than it is in spinal. Perinatal death is almost is twice as likely as well in general anesthesia versus spinal anesthesia. Postpartum hemorrhage is almost 9 times as much, and intensive care unit admission is increased. And the APGAR scores for the baby at 1 and 5 minutes are also worse. Oops. Okay, so there was no comparative data available for physician versus non-physician provider of anesthetic care. But when you look at prevalence data for studies that gave estimates for physicians and those who gave estimates for non-physicians, the overall risk of any maternal death when a non-physician operated was 9.8 per 1,000 women. And the rate of anesthesia attributed maternal death was 1.8 per 1,000. If you compared that to those who were operated on by a physician, that was 5.2 per 1,000 for any maternal death and 1.3 per 1,000 for anesthesia attributed maternal death, respectively. One study looked specifically at those who'd had formal training, looked at non-physicians who'd had formal training versus those who hadn't had formal training. And the odds ratio was almost 3 times as much for those who hadn't had formal training compared to those who have. So looking at the causes of the underlying death, only 24 studies gave detailed information about the causes of death, and that was for 124 maternal deaths. Out of those, 45% resulted from airway complications such as difficult or failed tracheal intubation, esophageal intubation, bronchospasm, or ventilation difficulties and hypoxia. 31% from pulmonary aspiration, 27 from issues related to staff competency, poor pre-assessment, intraoperative monitoring, and equipment failure. And other causes included cardiac arrest at induction or during the procedure at 6%. High spinal anesthesia was also 6%, and drug overdose or adverse reactions was also 6%. So overall in the discussion, it's clear to see that anesthesia contributes disproportionately to maternal mortality in low and middle income countries, with the main risk factors being exposure to general anesthesia and administration by a non-physician anesthesia, especially those who've been poorly trained. The causes of deaths are predictable and manageable with training. The list of deaths were nothing out of the ordinary. Looking a bit more detail about the limitations of the studies. So when you're comparing physician and non-physician providers, there's no comparative data, and that always gives a bit of room for bias. There were fewer studies from the very low income countries, and the rates are probably expected to be lower, which would change the overall rate. There was significant heterogeneity with it found despite adjusting for various factors. And that's probably because of the variability in the characteristics of the population setting, the type of anesthesia, whether the availability of cesarean sections and the provider. That said as well, when you've got such large numbers, heterogeneity tends to be higher. There were a few studies which provided detailed reports on the underlying cause of death. Also, there's confounding factors. So the people who have cesarean sections obviously have it for a reason. So they would have already had possibly preeclampsia. They may have already had a bit of bleeding, and it's difficult to always ascertain the cause of death from the indication of the cesarean section. However, when it was anesthetic related, it was a little bit easier to ascertain, although they may have obviously contributed. The underlying condition may have also had a contributing factor. So overall conclusions and recommendations: there needs to be better global definitions of and classifications of anesthesia attributed deaths, and that needs to be standardized if we're going to understand the real burden of the problem. There needs to be strategies to reduce maternal mortality, and that should include increasing the number of anesthetic providers, managing pregnancy, enhancing resources to them, and increasing their level of training. Simple measures such as pulse oximetry and WHO-safe surgical checklists before, during, and surgery may also help. Anaesthetists should be part of the panel analysing the cause of death, so that it's easier to ascertain how much to attribute anaesthesia, how much anaesthesia contributed to the maternal death or not. And there should be a wide investment in obstetric anesthesia generally in order to improve outcomes. Any questions? Is anyone still there? What was that, Stuart? Thank you. Yeah. Yeah. I've got a supervisor who kept making me go back and said the numbers were too small, so that helped. So yeah, I think you did need to keep it really broad, because the studies were from various different types of kind of papers. So in order to capture it all, we did keep it quite broad. So it was actually, we used the, as it was defined by the authors in the papers. So they often gave the number of deaths related to anesthesia in their analysis, and that's what we used. So that's why I kind of went on to say one of the things we need is to standardize the definitions. But you'll notice that I've kind of put a couple of things. So I've said anesthesia attributable and anesthesia related. So anesthesia attributable were those where they've said anesthesia was the cause. So they, had a bronchospasm or failed intubation or high spinal. Whereas anesthesia related is where it contributed but wasn't entirely the cause. So they've had an anesthetic and it contributed, but it wasn't in the entire cause of death. But where I've said attributed, then the author themselves have specified that it was anesthesia that caused the death. Sorry, I can't hear you very well. Say that again.
Why was 2000 chosen as a cutoff?
I think we just wanted to keep it quite recent, and with 2000 was when thereabouts was when all the Millennium Development Goals and things started. We didn't want to go too far back because obviously surgery, anesthesia, and maternal mortality have come a long way since then. So we wanted to keep the estimates relatively up to date. So did you say, so was it the physicians that were doing most of the generals? So let me just have a quick look. So I don't think there was a discrepancy in terms of physicians doing most of the generals, etc. In fact, in some of the rural settings, general anesthesia was what was used everywhere, as opposed to, because it seemed, well, it was deemed to be easier, and they didn't always have the spinal kits and equipment. So I don't think there was a difference in terms of practitioner. I think spinals were more likely to be done in kind of urban settings and more teaching hospitals because they tended to have the equipment and had the training and knew that that it was better. But there wasn't really a distinction. In terms of numbers, I'm just trying to look at the number of events and the number of women to see if there was a lot more in one than the other. Yeah, there isn't a huge amount. Yeah.
From your findings, what intervention would you prioritize most in terms of tackling the differences here?
I think it would probably be kind of increasing the availability, but also the quality. So just training. I think training is probably the best things in terms of giving the anesthesia and also how to deal with emergencies arising from them. Because I guess anyone can probably put someone to sleep, but if there's any complications, it's knowing how to manage them. That's the issue.
But is workforce scale most likely going to necessitate task shifting, task sharing, or?
I think at the moment, we're gonna, you're not gonna suddenly wake up to loads more physicians overnight. So task shifting is going to always play a part, but we just need to improve the training that the non-physicians are having. Because from some of the papers that I read, it was literally sometimes a couple of weeks training and on the job kind of, see a couple, then get on and do them. And I think that needs to improve.
More like competency-based training and certification.
Yeah. And if we're limited in terms of physicians, then they should maybe have more of an overseeing kind of training kind of role.
Mm-hmm.
Yeah. Give me 2 seconds. I've got it in here somewhere. I can't remember the exact.
Paragraph 2 of your discussion.
Yeah.
Halfway down. 0.5 of your 20.
Yeah. So looking at the USA, for example, there's a case fatality rate from general and regional anesthesia for cesarean section was 6.5 and 3.8 per million. Whereas our anesthetic related deaths in LMICs was 1.2 per 1,000. You do the maths because mine's rubbish, but it's considerably larger. Yeah. As in, have I? Yeah, so, I mean, I think when it first came out, there was a lot of tweeting going on, and the World Federation of Anesthesia kind of got hold of it as well, and were quite interested in the results, but I'm not sure very much more has come of it. But yeah, you're right, we do need to do that, and it's on the cards. Mm. Mm. Yeah. Yeah, no, I think I mean, things definitely need to change. But you're right, we do need to do more advocacy, and maybe that's something as GASOC we can take off as well. Any other questions about this one before we move to the next one? So not necessarily anesthesia specifically, but I'm currently doing a similarly large review on cesarean section related mortality. And I guess a subset of those would still be anesthesia, as we've described. But I haven't planned on doing anything more in terms of data synthesis. I mean, it would be good to kind of do some kind of interventional trial, but it just need a lot more thought in terms of what would need to do really. So nothing planned as yet, basically. Open to suggestions, though. Yeah. I did another review related, but looking specifically at women with preeclampsia, because they're particularly high risk for anesthesia, and the rates of death and poor outcomes related to general anesthesia in that population is even worse than the general population, almost 3 times as much. So I think that's definitely something we should be advocating more, spinals. But again, in the right hands and done safely, because there was the confidential inquiry in South Africa found that there were a lot more deaths related to spinal anesthesia because suddenly everyone thought they're really easy and they're a lot safer and started doing them with very minimal training and supervision. And in poor cases, i.e. those who are already hypovolemic or lost lots of blood and therefore died because of spinal. So I don't think we should just go around advocating spinal willy-nilly, but it needs to come with the appropriate level of training as well. Okay, let's do the next one. I apologize in advance for the heavy text slides. Okay. So this one was a paper in the New England Journal by Catherine Simru, published December 2017, and just titled Outcomes of Coaching-Based WHO Safe Childbirth Checklist Program in India. Just a quick history of safety checklists. This originally came back and has its history rooted in military and aviation. Basically, during the war, there was a big competition to pick the next best fighter plane, and a contest between 3 planes. The Boeing Model 299 was set to win, and it was nicknamed the Flying Fortress, and the competition was almost seen as just a formality. It was flown by 2 really experienced Army pilots and the mechanic, and after takeoff, they began to climb, but within seconds, they hit the ground and burst into flames. So the difference with this model is quite a complex aircraft with additional controls and instruments, and they weren't particularly used to it. When they looked into what caused the malfunction, they didn't find anything mechanical and put it down to a pilot error. A newspaper then went on and said that the Model 299 was just too much plane for one man to fly. They found that it wasn't that it was too much for one man, but it was too much for one person to just remember by themselves. And so they started a simple checklists to ensure that none of the crucial steps during the flight periods were forgotten. And there were 4 checklists developed, one at takeoff, flights, before landing and after landing. And it formed part of their kind of normal training, and they did lots of practicing on it. And that's how safety checklists started. Can't remember where this quote came from, but it was said that the checklist approach has the same potential to save lives and prevent morbidity in medicine that it did in aviation over 70 years ago, by ensuring that simple standards are applied for every patient every time. So where have checklists been used in medicine so far? So there was a small checklist, five item for central line placement, which reduced catheter-related bloodstream infections by 2/3 in a study in the US. There's a surgical safety checklist that everyone is familiar with, and that's a 2-minute checklist devised for surgical teams to assure adherence to practices identified as critical for safe surgery. In a pilot study, the tool was implemented in 8 hospitals, and the death rates fell significantly from 1.5 to 0.8%, and that was found to be replicated in bigger studies. And the checklist is now recommended globally. In more than 20 countries have already implemented it as its national policy. So we've touched on this already in the last paper, but in more of the 130 million births each year, the WHO estimates that there's nearly 287,000 maternal deaths, 1 million intrapartum related stillbirth, and 3 million newborn deaths. And the greatest burden of maternal and perinatal mortality is around the time of birth, with the majority of deaths occurring within the first 24 hours after childbirth. So the WHO, in their effort to reduce the number of maternal stillbirths and neonatal deaths, established the Safe Childbirth Checklist Program. And that synthesizes existing evidence-based WHO guidelines and recommendations into a single and practical bedside tool targeted at improving adherence to best practice, including adequate communication around the time of delivery. It's a 29-item checklist. Each item forms a critical action that is commonly missed but proven or considered to reduce death or major complication. It's initiated for use at 4 critical junctions around the time of birth, and that's on admission of the mother to the birth facility, when the mother begins to push, or before cesarean section, soon after birth, or before discharge from the birth facility. I'll show a picture of it at the end, but basically questions for the first one, like how many centimeters as a woman should you be starting the WHO partogram? And then when the woman begins to push or before cesarean section, you want to make sure your equipment is ready. So do you have clean gloves? Do you have clean scissors? Soon after birth, within 1 hour, you want to give oxytocin within a minute, check the bleeding, and check their observations. And before discharge from the birth facility is the last check. And the checklist items target the major killers, so hemorrhage, infection, prolonged or obstructed labor, and hypertensive-related disorders, as well as poor outcomes for the babies, like infection, asphyxia, and complication related to prematurity. So the aim of the study was to see if the checklist improves maternal and perinatal outcomes as a And the hypothesis was that the intervention implemented at the facility level would result in a reduction in a composite outcome of stillbirth, early neonatal death, maternal death, or maternal severe complications during the first 7 days postnatally. So it was a matched pair cluster randomized controlled trial in government health facilities, and facilities were randomized to either the Better Birth program, which is a coaching-based implementation of the WHO Safe Childbirth checklist, or existing care. So 60 pairs of facilities across 24 districts of Uttar Pradesh, which is one district in India, were used. The matching was done at facility level on the basis of the following criteria before randomization. So geographical zone, functional classification, i.e. whether it was a primary health center or a community health center or a referral center, distance to a district hospital, birth volume, and the number of birth attendants. And these were randomly assigned to either the trial group or the control group within each matched pair. Okay, forget that slide. Don't know where that was. So the intervention was done in terms of a coaching method with coach leaders carrying out the intervention and training and monitoring throughout. So they had commitment from the leadership of the state, the districts, and the hospitals. They had motivational events, and they had coaching peer-to-peer models. They shared the feedback of the data using visual charts and tried to build it to make it sustainable by having a champion within each area to try and keep people pushing and using the checklist. So to begin with, the coach leader would visit once a week, and then that was twice a week, and then once a week, once fortnightly, and then once a month. And they did this for a total of 8 months. So the primary outcome was a composite outcome of events occurring within the first 7 days after delivery, incorporating stillbirth, early neonatal death, maternal death, or self-reported maternal severe complications, including seizures, loss of consciousness for more than an hour, fever with foul-smelling vaginal discharge, hemorrhage, or stroke. And then secondary outcomes were split between maternal and newborn. Maternal outcomes included 7 days after delivery, were counted for 7 days after delivery, which were maternal death, needing to transfer the woman, cesarean sections, hysterectomy, blood transfusion, and coming back for a health problem, with the newborn outcomes including stillbirths, early neonatal death, and inter-facility transfers. So all outcomes were assessed from facility register information and by contacting the women or close family members by telephone between 8 and 22 days after delivery. If they didn't get any response by 22 days, then they would arrange a home visit. So this is a figure showing the randomization. Sorry, give me 2 seconds. Showing the randomization of both groups, and they were matched 1-to-1 and underwent randomization to either the interventional or the control groups. Of all the eligible women, 97.7% provided consent, and they collected 7-day outcomes for all but 544 women, so 0.3% of the consenting women. So that was quite good overall. So looking at the characteristics between the interventional and the control group, there was no significant difference between both groups. There was slightly higher birth rate in the control group, but in terms of the outcomes, there wasn't very much. And the program was successfully implemented in all of the 60 interventions, with the right number of visits by the coaches in all accounts. So you can see that there was a significant difference between the intervention and the control group among most of the outcomes at 2 months. And for the majority, that was still present at 12 months, although that had dropped for a few of them. So after 2 weeks of twice-weekly coaching, birth attendants in the interventional facility performed on average 72.8% of the 18 measured practice, whereas birth attendants in the control groups performed 41.7% of the practices. And the birth attendants performed the majority of specific practices such as blood pressure and temperature measurements, proper hand hygiene, and early newborn care at significantly higher rates in the interventional group than in the control group. Although adherence in the interventional facilities remained significantly higher than in the control facility throughout the trial, adherence to the interventional group had decreased to 61.7% of practices at 12 months or 4 months after coaching had ceased. For example, administering oxytocin soon after delivery decreased by nearly 1/3 from 79.5% to 53.9% between 2 and 12 months. Looking at the primary and secondary outcomes in women and their newborns, there was no significant difference between the interventional and the control group in the primary outcomes. And there was no significant difference in the follow-up care for the secondary outcomes either. So discussion and limitations. So the quality of care in the control sites was far lower than previously recognized. So the overall birth attendants in control facilities performed approximately 40% of measured essential practices in a typical birth. E.g., for example, hand hygiene was only done in 1% of deliveries. And oxytocin use in the first minute was less than 25%. At 2 months, the rate of performing recommended practices was significantly higher in the interventional site than in the control sites, whereas some practices were rarely performed. During the coaching intervention, staff at intervention facilities had correspondingly higher rates of checklist use. However, overall levels of adherence and checklist use diminished after coaching ceased, and the rates of some practices never differed significantly between the intervention and the control group. So it's possible that checklist use wasn't sustained because of a lack of checklists, or maybe the staff knew what was on the checklist and therefore didn't use it, or just a general lack of enthusiasm for its use when they were no longer being monitored. However, overall, although there was better adherence to the birth practices in the interventional group than the control group, it may not have been enough to affect the outcomes. So, for example, the birth attendants performed appropriately hand hygiene in only 35% of cases, which is still quite poor, but better than the 1% in the control group. Although 79% of mother-infant pairs initiated skin-to-skin warming, only 19% maintained it for up to an hour. For example, the use of magnesium sulfate was no higher in the interventional facilities than in the control facilities. And there was persistent gaps in technical skills, management of complications, quality and quantity of supplies and medicines, access to supportive management. These could have all contributed but weren't adequately measured, or they weren't really measured in the study, and could have had an effect on the health outcomes. There were other factors that weren't targeted by the Better Birth group, so the type of antenatal or postnatal care the woman received, which would have had an effect on the outcomes, but weren't targeted by the checklist. So some of the limitations, data on the observed adherence to practice were only available for a sub-select group. So on the outcome data, they had them for the majority of women. But looking at the adherence to practice was only for a subgroup of women, and that was 4,888 out of the 157,000. And for practical reasons, the observations were done at non-randomly selected sites and during daytime hours, which would have affected the generalizability of the results. And also, if people knew that they were being observed, that may have affected their, how they filled in the checklists and their adherence to it. So especially the secondary outcomes, maternal complications were reported by the patient. And although this method has been validated previously, it can still cause misreporting. Also, the outcomes for the 7 days were collected between 8 and 42 days after delivery, and that may have contributed to recall balance, which could affect the outcome reporting for morbidity, but wouldn't affect mortality. The study was carried out in just one region in one country, which limits the generalizability of the findings somewhat. So in a different setting with different populations or a higher standard of care to begin with, the findings may be different. And just a general discussion about checklists. So it's been debated about how, the efficacy of checklist implementation, and there's been, there's lots of reasons why they don't necessarily work, and the success, it requires quite complex interventions because it factors on cultural, it needs cultural and organizational change, and it's confounded by a mix of technical and other elements, and the local context is really important, and may undermine the implementation. And also, everyone loves checklists and they're a new big thing, but implementation of checklists may erode respect for long-standing healthcare cognitive aids that are effective. So if you bring too many checklists, people will just start ignoring them, and those that are actually useful will not be used in the long run. So if you give me a second, I will just bring up the checklist, and then we will have a discussion. But if you've got any questions in the meantime, I am happy to answer them. Can I see that? Yeah.
He did do a TED Talk on it and made it seem phenomenal.
Hey, it still got published in the New England Journal, so it's all good.
Why did it get published there? From a personal perspective, I think they're still, I mean, the New England Journal really tries to publish huge RCTs, and even though this is a negative finding, it's a critical, I mean, publishing the negative data is something that they're trying to advocate for, even when it's this big of an RCT still.
Yeah, I mean, we should definitely still be publishing them. And it does still show that the checklist has helped in terms of improving some of the adherence to the checklist. It just might have been that the standards were so poor to begin with that even though they improved, they weren't enough to have an impact on outcomes. And it may also be that once the kind of the 8-month period where the coaches were coming in was over, that the use of the checklist kind of died down, which would have affected the outcomes for the later part as well. But as a concept, it does improve kind of adherence to these factors, which are really important. So I'll just run through the checklist so you know what it actually includes. So if a woman presents to a facility, you need to ask if she needs referral or if she's in the right place. And if she's in labor, if she's more than 4 centimeters, whether you've started a partogram. Does the woman need antibiotics or magnesium sulfate for hypertension? So the other thing that wasn't clear from the paper was whether they just kind of counted the yes, no's bit. Because the other thing is a list is just a list. So if you tick no, but then don't do anything about it, it's not going to improve the outcomes. And I'm not sure if it wasn't clear whether they kind of looked at whether they then got the antibiotics that they needed or whether they got the magnesium sulfate that they needed or not. So that was another limitation. So whether they've got a birth companion will help during labor if needed. So this is probably more in a kind of rural setting, or if it's not one-to-one care, which is often tell the companion to call for help if there's any of these issues, so bleeding, severe abdominal pain or headaches. And then the second stage is just before they start pushing, and you ask again, do they need antibiotics? Magnesium, do they need magnesium sulfate? And the other thing was it kind of gave a total mark on the checklist. So observations were kind of counted once. So did they check a temperature at some point? They got a tick. Did they check a blood pressure at some point? They got a tick. But not, it didn't. So, and it did that so it wouldn't be counted several times. But obviously it needed to have been checked several times. So that was, again, a point in the analysis. So at the bedside, prepare for delivery for the mother. Do you have gloves, alcohol-based hand rub, or soap and water, oxytocin, 10 units. For the baby, if you've got a clean towel, tie, sterile blade to cut it, a suction device, bag and mask. So you can see that this can be used kind of from the very rural kind of birth centers to, the hospitals. Soon after bleeding, you're asked, is the mother bleeding abnormally, yes or no? And if it's yes, shout for help and do the stuff on the right. Again, it quizzes you as to whether she needs antibiotics or magnesium sulfate. Check the baby, and does it need referral? Does it need antibiotics, or is there any special care or monitoring? Before discharge, again, does the mother need antibiotics? Is her blood pressure normal? Is she bleeding abnormally? Is the baby okay, or does the baby need antibiotics? And it gives you criteria to start the antibiotics if needed. Is the baby feeding well? Arrange any follow-up and required, and inform them of any kind of the danger signs, essentially. So it is stuff that is relatively basic and should be happening all the time anyway, but isn't always. Yeah. Any thoughts, questions, points?
Was adherence whether the box was ticked or whether the practice was adhered to?
So it wasn't entirely clear. So at one point it does say that the coaches kind of would observe them. And so I think it's if the actual things were done. But I'm not sure to what level, whether it's just kind of in terms of filling in the form or actually carrying out the task. I didn't find that it was very clear, to be honest. It did have an 83-page protocol online, which I didn't manage to go through all of it, I'm afraid.
You can see under each timing of the checklist, though, the checklist wasn't even used at 56% for the person at admission.
Yeah.
But 100% of the birth containment is present. So yeah, a lot of these are from the observer data.
Yeah. Yeah, so I think these were all observed from the 4,000. Yeah, from the 4,888 women that they were not randomly selected.
Should the whole trial be repeated? Elsewhere?
I mean, it'll be different. It'll be interesting to see if it makes a difference in a different setting, or if it's carried on for longer, but with the coach going in for a longer period. Whether it would make a difference. It's not that the problem with the coaching. I guess when the coaches were there, they were more likely to use it. So the adherence to the checklist itself decreased after the coaches had gone. So whether you need to kind of embed it more and within the system, although they seem to have done that quite well, to be honest. But whether they need to kind of figure out ways to keep it going longer than just when they know they're being observed, or when the coaches are around, or for the period that they know the study is going on. I mean, I don't know if they're still using it. That'd be something that'd be interesting to find out, and what the rate of use is now. I can see it being, in terms of the checklist, I can see it, like I said, I can see it being a bit of a tick box exercise if it's not used properly, without the necessary intervention actually being initiated. But yeah. Yeah, which is one of the reasons I'm wondering if they, it's one thing taking a blood pressure, it's another thing acting on an abnormal finding. Yeah. Why they didn't make a difference.
Yeah, I mean, are antibiotics something to pay for example?
Where does the sound come from? Yeah, that's a really interesting point, actually. Yeah, there's no information, but that's a really, really important point, actually. The point about the blood pressure that you point, Stuart, if you look at the 12-month, it's dropped down to 21%, which is still better than 1%. you can see just with time that the things have already started to fade. And same with temperature, it's gone from 54 to 15.
So that's a similar pattern we've seen in a lot of the other surgical checklists as well. The sustainability of the practices, whether it's just behavioral, it's more of just a behavioral trend that's commonly seen in the other checklist data.
I think some of the smaller pilot studies using this checklist has shown a difference, but then the methodology wasn't as robust as it was with this study. But it may be just different settings as well. It works better in, I think the other pilot I saw was also in India. I found it in rural Brazil as well, I think. What do you think about the point about checklist overuse and draining?
I guess it's really hard to say without having to do that year cultural context. Here,
Oh no. But just kind of, I don't think it is either. But just as a concept, with there's almost a checklist coming out for everything, and they are helpful. But I wonder if sometimes we've gone too far the other way with them. And again, not India specific, but just as a general point. I didn't actually look at that paper in any detail.
So we've discussed this in the Global Surgery Masters course. And so what they did with those original sites in the Alex Haynes paper in 2009, there was a huge investment too in training and getting teams really all on board in terms of implementation and following the checklist. One critique of the paper in Canada that came out later that said that the checklists don't work. It was also a New England Journal paper. That was a mandated, mandated to use the checklist. There was no training period, and then it was self-reporting adherence to the checklist. So you can kind of interpret if mandated and you have to report use or not. There's suspicion that most people will just say that they're using it. So adherence to the checklist is a huge issue, and behavior change is always a struggle. And I think that the time investment ahead of time for any checklist implementation is, the critical analysis is thought to be a really big part, though there are many other parts probably.
Yeah, I think that's a really interesting important context in the original one paper. I think there were 8 sites, and they were all volunteer sites. We can't really get in paper because these are 120 people really want to take part at all. government of the current against the idea,
Mhm.
and there was a bit of backlash against it. But there's been quite a fine Yeah. Although when the original public research paper, the reduction in mortality reached significance in the low and middle income countries and actually didn't in the high income countries. There was a difference in the morbidity to in both high and both middle income sectors. Yeah, I think partly it was a problem with eventually.
Yeah, I was about to say, was it powered?
About 1%, whereas the event rate here is 15%, so it should have been much easier to do it.
Not just a checklist, it's quite hard thing.
Yeah, at one point it said, that there was differences in nutrition and underlying medical conditions, and sectors probably wouldn't have much of an impact on kind of the underlying health of women if it was pretty poor to begin with. But
I think it's how much longer time maternal health checklist covered, like almost like it's done this kind of and almost like you don't just have one person doing this, at the staff names are specific for all these different stages of personnel who are going to be involved. So I just wonder whether that makes sense.
Yeah, that makes sense. I was thinking something similar, yeah.
But I guess one person would be doing at least one section before they move on. So someone might triage and admit them, and someone else might deliver them, but it would be the same person doing each bit, maybe.
Yeah, true, but I guess it's just that people like to separate themselves.
Mm.
The other question is what something does. I think it will back to one thing. Which checklist?
If the surgical safety checklist is published in 2009, I think.
Yeah, Guale was senior author, Alex Haynes was first author.
this you can utilize. Yeah, no, I just think whether it's concept areas, I was just wondering how much emphasis and this. Yeah. I see what you mean, like, I'm glad you also is effective in terms of the develop one working there. And what we're doing is culture and
So in the protocol, it said that this checklist was still in the pilot stage and may change further. But I don't know if that's happened since. Any further questions?
Has there been any response platform online right now? Draw any more insight into why the authors felt that we ended up with study?
Have there been any letters that followed this?
There was only 3 comments after the paper, and they just said great intervention and good that people are investing in India. That was all that was said that I could see.
No published letters yet, right?
So I don't know if there was a preface, like, there was forwards with it. I didn't check. Just take note.
Well, thank you very much for this. I really interesting paper.
Thank you.
Thank you all for joining.
thank you, Sarah. Thank you.
Yeah, it's really impressive.
2 years. Yeah, but I mean, I think you're all right. I do need to do more with the results because they are very interesting. But it's just kind of trying to get them out there and make a difference with them somehow. Great, thank you everyone. Bye.
You all. Have a good rest of your evening.
You as well.
Bye.
And you can just hang out. And then you want to go to this, the live stream? No. I think I already have, did I? Because it was being shared with me. Oh, okay. But I don't know. Look at it. Click down. Live now. Oh, darn. Exit. Let's just close it. Don't close it. Pause. Still streaming something somewhere. It's only a scene.
Yeah.
Oh, I think this is this.
What about it? You
No,
can still hear
it's
us.
this.
Yeah.
No, it's this playing. It's this playing.
Oh. Okay, so I'm just talking to the room. Okay. Okay. So it's done.
Okay. Good.
Okay. Yeah, just
Let's
exit
close
out.
it.
Yeah.
Thanks so much, by the way, for your help. The total
There it is, stuff.